My first important job is to acknowledge country. I'd like to acknowledge the traditional owners of the lands in which we stand and meet, particularly the Ngunnawal people in Canberra, who in that space, in my space where I'm coming from, Bundaberg, it's the Terbalang, Garangarang and Bunda peoples. I want to acknowledge elders past and present and those emerging, and the country that we live and work on. Thank you. Just a few slides from me. Just to let you know a little bit about Strongyloides Australia Inc. We first began as a group, the National Strongyloidiasis Working Group, in 2001. So this is our 20-year anniversary, if you like. The late Emeritus Professor Rick Spear was the first chair of this group and remained so for many years until he passed in 5 years ago. We incorporated in 2019 as Strongyloides Australia Inc. We have conducted 14 national workshops, and we are a multidisciplinary group including parasitologists, veterinary and molecular scientists, pathologists, environmental health officers, medical practitioners, health promotion and prevention professionals, and other interested people. Our aims as a group are to raise awareness of Strongyloides, to inform health professionals and community members about the disease and its diagnosis, treatment, prevention and control, and to advocate on behalf of affected people for appropriate changes to government policy in relation to prevention, diagnosis and treatment based on current research. Integrating Strongyloides research, prevention and control programs with initiatives addressing comorbidities such as intestinal parasites, scabies, HTLV1, trachoma and chronic diseases. Our outcomes to date are that we have successfully worked with a number of Aboriginal community members of the working group have been involved in developing in partnership with these communities a number of approaches, including engagement strategies, clinical audits, mass drug administration, infrastructure upgrades, and community-based education programs. Our research has been published in peer-reviewed journals. We have quite a few papers together as a group as well as separately in the Strongyloides space, and a few people who have gained their theses as such.
Okay, I'll turn you off, see how it goes. Great, thank you, Toby.
Sorry, we've now got Wendy joining us. That's very good. The Strongyloides is the most neglected tropical disease. Our aim is to prevent and control Strongyloides in endemic Indigenous communities in Australia. Neglected tropical diseases, as you all know probably from joining this group, are a group of communicable diseases that prevail in tropical and subtropical conditions in 149 countries. They affect more than 1 billion people and cost developing economies billions of dollars every year. Populations living in poverty without adequate sanitation and in close contact with infectious vectors and domestic animals and livestock are those worst affected. The Sustainable Development Goals call for an integrated response, the kind that has defined neglected tropical disease efforts in the past decade. Strongyloides, a parasitic worm, is a soil-transmitted helminth and the most neglected of the neglected tropical diseases. Strongyloides cercoralis infects more than 60 million in tropical and subtropical regions, but Strongyloides is underestimated, underdiagnosed in many countries, and there is a paucity of research and public health efforts pertaining to Strongyloides. In Australia, it is endemic in many Indigenous communities, and we have evidence that the prevalence in some of these communities may be up to 40%. A One Health approach may provide the best framework for preventing and eliminating Strongyloides, and if successful, can inform approaches more globally in endemic areas. There are 5 strategies to answer this question: an assessment of prevalence and disease burden of strongyloides in different epidemiologic settings, the development of novel diagnostic methods, including screening patients of highest risk, clinical management approaches, and enhancing availability of and access to ivermectin, including research and development on alternative drugs and treatment regimes. Public health strategies for control in endemic settings: WASH activities, water, sanitation and hygiene, and environmental interventions. We have a crack multidisciplinary team in this group to address these issues. Our team includes pathologists, serologists, parasitologists, veterinary scientists, public health physicians, epidemiologists, infectious diseases physicians, health promotion, environmental scientists, and genetic experts, and some not-for-profit organisations such as One Medicine and Animal Management in Rural and Remote Communities, or AMRIC, who will work together to find the best ways to prevent, control strongyloides in Australia, therefore inform global efforts to eliminate this disease. That's basically my presentation to you this morning, to introduce you to this group of ours called Strongyloides Inc. We're fairly passionate about trying to address this issue in Australia. Remarkably, we're a developed country who still has a range of people affected by this particular disease. Thank you. So, do I hand over to Wendy?
Thanks, Jenny.
Okay.
Great introduction. We'll now hand over to Dr. Wendy Page, who's the 2021 Northern Territory Australian of the Year and a passionate GP up in the Northern Territory. So over to you, Wendy.
I'm unmuting. Can you hear me?
Yes.
Yes, we can hear you.
Okay, I've just got some technical challenges, not being very techno-savvy. Yeah, so I've just got to work out how to share the screen. On here, on Zoom, Zoom. I've got my PowerPoint up, just not how to put it across, sorry.
Wendy, when you click share screen, can you see your presentation window as one of the options?
I don't know how to make you bigger. Exit the minimize video. Share screen. Okay, let's see how we go. I'm going with screen 2. PowerPoint slideshow. Does that come up?
It looks good, Wendy.
It's good to you.
Good to go, Wendy.
Okay. Have you got the full screen? I've got
Yep.
2 screens, so it's a bit
Yeah.
okay. Well, just a thank you to everyone for actually being here. 7:30 in the Northern Territory time. And yes, this is the photo you can see is a place that is very special. It's the tip of northeast Arnhem Land. It's where the Arafura Sea in the north of Australia connects to the Gulf of Carpentaria. And it's a place where I've had the absolute privilege of living and working from 1993. It's traditional Aboriginal land, and I pay respect not just to the owners in Canberra, all Aboriginal people within Australia, but in particular the traditional owners of this area, and we're on Wiradjuri land. The reason just to say that coming to here is probably been the best job in the world. Just working with Yolngu people in this region, northeast Arnhem Land, has been the best job in the world. The challenge is that very unfortunately, we have some of the highest rates of death in the country. And one of the contributors that is rarely seen elsewhere, but has been very common here, is disseminated strongyloidiasis. Now, in terms of the background, as a GP, I probably knew very little about strongyloides, just that it was a soil-transmitted helminth, which WHO still categorises it within. And Rick Spear brought out the microscopes from JCU in 1995, and we found that we had all the parasites, all the helminths within the human helminths within the town square, and the most significant of these was Strongyloides stercoralis. So in the following year, we opened a clinic, and I wondered why a 25-year-old male who had rheumatic heart disease, presented with sepsis, a bacteremia, which was life-threatening. He didn't want to stay in hospital. It grew the gram-negative bugs. He didn't want to stay in hospital. We had to give the IV drugs in his home. And that was the challenges with people not necessarily wanting to engage with the health system. And then later that year, he represented, and I thought, oh, could it be strongyloides? I'd heard that bacteremia, septicemia, is something you can get with strongyloides. So yes, he did. We treated him with multiple doses of albendazole, and he's still doing well at probably 51 years of age now. So, you know, that's someone who has survived, and yet back in those days, people would say, oh, it's just the environment, you know, it's just, oh, you know, conditions that people live in. So we then looked at unwell patients as they came through, and we started to identify that anyone was unwell was looking at it with looking for strongyloides as a cause. And then it started to unfold that obviously I was living in an area and working as a GP in an area which had hyperendemic levels of Strongyloides stercoralis, but in particular strongyloidiasis. So we're travelling along that path with certainly the support from Rick Spear and the microbiology, the microscopes coming out, and the teams that wanted to teach about you know, the importance of the helminths that we had, and other conditions as well. In 1999, a colleague, a senior Aboriginal health worker and traditional owner, died from disseminated strongyloidiasis. She had a medical condition. We sent her off for investigation. She was unwell. Serology took 3 weeks back then to get a result back. And she didn't return home to be managed with the cancer that she developed. She died in Adelaide from disseminated strongyloidiasis. Didn't come back on electronic discharge note. It came back as a paper file, and disseminated strongyloidiasis was handwritten. The rest of it was typed, but obviously the person on the dictaphone wasn't familiar. So we're at a point that very few people knew about it, but for whatever reason, her diagnosis was made, and she sat on my shoulder, and this incredibly strong woman, a huge loss to her community, a queen for her people, was saying, if we've got this strongyloides, we need to get rid of it. And so then we're just looking to do more. The following year, we introduced ivermectin following some other cases. And then in 2001, we held the first national workshop on strongyloidiasis in Gove. And that was a pretty amazing workshop, lots of enthusiasts. We had a microscopy session with the Aboriginal health workers before. There was a lot of interest and enthusiasm to do things. From that, we formed the first national workshop. We formed the National Strongyloidiasis Working Group. At this workshop, a senior elder who has since passed, had listened to the stories from many people, from the respiratory physician, from others in other places, parasitologists who had attended. And she said, we've had this Strongyloides for so long, why hasn't something been done about it? And it was a call to do something. We formed our network, and then we took different steps. That was 20 years ago. So we want to try and cover what we've actually done in that 20 years, and then what we need to do to take it further, because we do want to end the neglect. The first step, this is the first step Rick would usually do, is tell us about understanding the Strongyloides stercoralis. It's the cause. It is under the soil transmitted helminths, but what makes it Strongyloides different? I focused on the auto-infective cycle because that's, as a clinician, as a GP, what does it do to the body? But this life cycle here, has it gone through, or am I looking on the wrong page? Are people looking at, are you able to see the change? I'm changing the slide.
No, it's not.
No, we
it's
can't
not
see that.
changing.
Okay. Resume the slideshow. It's on 2 screens for whatever reason. I'm just going to turn off one screen. Working off a laptop. Okay, the screen is paused. I'm sharing. Let's see how we go. Okay, sorry.
Okay, so that's okay. We've got background in front of us right now. So if you forward through, maybe that's...
Get back on track?
That's it. Beautiful.
Okay.
Yes.
So I am in one of the most remote places in Australia. It says the internet's unstable, but we're still going to work through it because there's we learned lots of resilience and persistence. That's part of what you learn in this area. So this particular life cycle is 2015. One of the areas that parasitologists knew, but was not clear on the CDC life cycle, was that this particular indirect life cycle, where there's a male and female, that's the male, that's the female. The female and the male do not have, there's not another arrow. Somewhere along the line, people thought there was another arrow, and Strongyloides stercoralis continued multiplying in the soil. That's not true. There's only a single generation. All the progeny that comes from this female goes through, and it's that's the baby larvae, and this is the teenage larvae looking for a host. It's looking for a human host. Wants to live in us. It loves living in us. In fact, it lives in us for decades. Where it's home. It loves humans. This is the falariform larvae that go directly to being infective larvae and coming into the host. This is what it comes out in feces, so it's fecal contaminated soil or an environment. So just noting that one of the myths that we've had to address is that it lives indefinitely in the soil. It's probably only a short period of time. We can't even send it off to the laboratory and expect it to be moving around. It needs to be fresh, hot and steamy to be seen. Okay, so this other cycle is what makes Strongyloides different. And we can see that it only lives in the body. These are the auto-infective larvae that come through and randomly migrate. We think it has an ordered life cycle, but when you see Strongyloides, you can see that that's something we'd like to put it in a box where it just goes, follows an ordered life cycle, but in fact it's random migration and can travel anywhere in the body. But it does, its life cycle is when it gets to the gut. Okay, so courtesy of Richard Bradbury and one of the papers we've written about dealing with some of the misconceptions. Let's see how we go. Here we go. So you can see, I hope everyone can see that screen, but there's the filariform larvae, that's mother in the middle, that's the female in the middle, and these are the, probably a small amount of rabidiform, but these are the filariform teenagers looking for a host. They're looking for a nice warm human who will keep them, allow them to reproduce in the human and keep them going for decades. Okay, so the next slide, this is the human. This is the female adult, the mother, and inside you can see inside are the eggs which are embryonated, and when they come out they're ready to hatch. They're ready to move, and there you go. You can see now this female is only 2 millimeters long, so it's microscopic. You're not going to see it without that. So that's introducing you to the star of the show, Strongyloides stercoralis. Quite an amazing parasite that we call the smart worm, because it evades it wasn't, yeah, we think, well, just cheekily, we've been a bit, we call it the smart worm because it seems to evade doctors being able to detect it. So what makes it different? Strongyloides is different from other worms. This is a flip chart that we developed following the workshop, and this is what makes Strongyloides different. It's the auto-infective larvae that can travel anywhere in the body and set up a cycle. So once you're infected, you're essentially infected for life. So, and what makes the other side, that what makes it different is when we become unwell, or particularly if people are going to be given corticosteroids when they're unwell, the mother says, we need to make more babies, we need to get out of here, our host is not well, we need to find another host. So not only are the larvae, not only are the feces infective, but the human host with disseminated strongyloidiasis is also infective. And that's where it's found in the sputum. If people look under the microscope with a wet sputum. Okay, so I'll just go through clinical manifestations. Because it can travel anywhere, it's not an overt disease. If you don't look for it, you won't find it. The microscopy, people who have been taught microscopy discover it. We have, these are some of the conditions. We can see pretty well all parts of the body are covered. Hypokalemia, wasting, this is something that's seen in the children, and that's what we were seeing in the children back in the, in the 2000s and earlier. The amount of children that are in remote sites would be evacuated because of gastrointestinal disease. And we had a case, we've had many cases presented along the way, but one of them of note was called The Early Bird Catches the Worm, and it was a child under 2 from Dumaji, went to Mount Isa Hospital, was then evacuated across to Townsville, life-threatening condition, and it was only when it was recognised in the laboratory, hey, this person's got strongyloides, you need to do something about it. So, it's something we need to get in earlier. This is larva currens, the only condition that you can see that has, it's the only sign. It's very hard to see on dark skin, very much easier to see on paler skin. And as you can see through there, and people think, what's this? What's this rash that comes and goes? And that's the larva currens that is the only pathognomonic site. But otherwise, there can be different urticaria, different rashes that come and go, respiratory signs. This is the larvae in the lung, obviously off a histology slide. Hemoptysis is something that is coughing blood, and that can be from different causes, but we had it from my side. We had a 33-year-old male, 3 young daughters, wife, traditional man, who actually exsanguinated from hemoptysis, and absolute tragedy, absolute tragedy. So, you know, these situations occur. Who dies from strongyloidiasis? We say, oh, it's not many. Well, we don't know because it's usually undetected. But patients in high risk groups, and they haven't been tested, no one thinks about it. Patients with clinical signs, but it hasn't been thought, oh, you know, could it be strongyloides? No tests have been done. Patients with cured strongyloidiasis, they think, all right, one dose is fine. We've given you albendazole. We don't need to do any further follow-up. The albendazole should have cured you. But we know that one remaining parasite can cause a reinfection, a recrudescence of infection. So it's a challenge. Strongyloides is remarkably persistent. Patients diagnosed with strongyloidiasis and they say, oh, it's just a worm, and the significance is missed. Oh, so, and then the immunosuppressed patients with no test done. I have to say, in hospitals now, we certainly in the Northern Territory have a policy that anyone who's about to be immunosuppressed, particularly with high-dose corticosteroids, should be given prophylactic ivermectin or tested before. So the big one to have a watch for, corticosteroids are commonly dispensed throughout Australia, and we still see cases that of disseminated strongyloidiasis because it hasn't been considered, and it seems that over 60% of fatalities are related to disseminated strongyloidiasis. What we now know is that there is a steroid hormone receptor, and it actually stimulates the dower female. This is this long-lived spent female. You know, you think, all right, she's older, she's not going to reproduce anymore. Well, give her some corticosteroids, and she's again capable of producing viable larvae when the host was treated with corticosteroids. So, you know, this is quite an amazing parasite, and it's got an amazing mechanism for wanting to stay around. So we'll move to the epidemiology. Initially in the 1980s, and they'd talk about 30 to 100, and you'd still see this. The latest estimate, 2018, is 614 million worldwide. So it's not going away. Strongyloides isn't going away. 76% in Southeast Asia, Africa, Western Pacific. We fall into the Western Pacific, and so does some of the countries in Asia, and we know Japan, the Okinawa area have lots of cases, particularly of meningitis, but they were only in people that were born before 1960. In Australia, the cases we see are either acquired overseas or they're acquired locally. In 2010, there was a paper by Swaminathan, the Geosentinel database for returned international travellers with infectious gastrointestinal disease. Strongyloides stercoralis is the 5th most common pathogen. So that was turning up in about 6% of the fecal studies. So this is an untapped area. We will be seeing more of strongyloides into the future. From within Australia, we know our hotspots have been in remote Aboriginal communities. And we've had contact with, a long time before Captain Cook, we've had contact with other areas, particularly Sulawesi. So, now, in terms of local transmission, we've had up to 60% prevalence, but we don't have any database. We've got no mechanism to measure what the current prevalence is or identify the endemic hotspots. This is something that was collated by our team, was collated with the cases that we were finding based on the published papers and what we had. This is also Central Australia. It doesn't just live in the warm, hot tropics. We know that people take it, people transport it. But you need an environment that enables that transmission. Just up here, that's our beautiful area. That's where I am. Come and visit, very special. Jenni Shield and her team have recently collated data that's 2012 to 2016. So we can see where the higher prevalence areas are. And but that takes a lot of work. It takes a lot of work to get that data and to get it from laboratory. We need a solution to being able to get accurate data readily. So this was something, again, this was 2002 to 2012 in the Northern Territory. We're making a difference. You can notice our area. This is Northeast Arnhem Land. That's our area. And we're no longer the highest rate. There are other places that have high rates. And what's being done in those other places. So we know we're doing positive work in this area, but more needs to be done in other areas. We've had lots of advances in knowledge, and I think we'll have covered some of those. The diagnostics will come out. It's a busy slide. In terms of time, I'll just move forward, but know that being community control programs, only disseminated strongyloidiasis is notifiable in the Northern Territory since 2011, and a lot of lobbying from our group. But you have to find it in the sputum. And one of the cases written up in 2003 was a person from Northeast Arnhem Land, a 19-year-old with systemic lupus, who was probably 3 months in hospital. And her case, the larvae, they kept on giving ivermectin, multiple doses beyond what was, the guidelines at the time, until the larvae stopped moving. But she survived. So, people that are in the Northern Territory, some have that awareness, but the awareness, we still need to raise awareness throughout Australia about strongyloidiasis. Okay, community education is key. Environmental health, that's how we actually prevent it. It's a basic human right, sustainable development goal. Number 6 is access to clean water and sanitation. And if we have that throughout our communities, we know that we can not just reduce the rates, but we can eliminate it. And we know this One Health approach, which has already been alluded to, is not just managing the humans. As health professionals, we can treat the humans, but we need a multidisciplinary approach across different disciplines to actually make that difference. Okay, so moving on to diagnosis and treatment. Faeces has been the main means for diagnosis. Serology, people thought didn't make a difference. Here's albendazole. Here's with giving 3 doses of albendazole, adding in an ivermectin, and here's what happens with ivermectin. So the work, because we had we knew it happened in smaller numbers, but with introducing ivermectin, this was really something that MeWatch needed to write up, because we had the numbers more that were able to show this difference. And following this, I know that the refugees in now the refugees coming into Australia are screened since 2010. It's part of their health assessment that they have as part of their health assessment, they're screened for strongyloides, and the positive cases are treated with ivermectin. So that's been a wonderful initiative, and thank Bev Biggs and the team that worked very hard in the refugee area. Okay, I'm putting this one up because one of the things we've learned with diagnostics is that people say, oh, serology versus faeces. Well, we know that faeces may or may not be positive. So strongyloides is often put into 3 categories. Acute strongyloidiasis is the first, is when they're getting it initially, and they can be unwell, or they might just have, it comes and goes and people just put up with their symptoms and the diarrhea is gone. So, but they're more likely to show positive faeces. It needs to be fresh, hot and steamy. These people are more likely possibly to be in hospital, which gives them a chance of being diagnosed if they're doing fresh, hot, steamy faeces, as looking at what's under the microscope. However, the serology at this point in time, in a new case, may well be negative. And we know that from people returning from overseas as well. In their first episode in this acute phase, they may well be negative. And then this is the lifelong phase. This is the phase where it's made it into the human and we've got this nice balancing, you know, gives the intermittent symptoms, you know, depending on where it travels. But the numbers aren't great within the body. There's a certain number and so the feces are usually negative on just one specimen, but the serology is usually positive. The later ones, we don't have the equivocal, we just now have positive or negative, which makes it sense because we found that the equivocal are more likely to be positive. They're just in this phase where it's hard to find the positive on the feces without multiple specimens. This is treatable. There's only a smaller number. This is a time to catch them. This is a time that, you know, we can do something about it. This is in the primary healthcare setting. When they're sick and they end up in hospital and, you know, in these conditions, sometimes they will look for it and sometimes they won't. So they can die from multiple end organ failure. They die from sepsis. Oh yes, it's just part of the, you know, the living conditions, etc. So just noting that people expect, and I can see sometimes with hospital specialists that they say, oh, you know, we can't rely on the serology. Well, if their immune system is dropping, then that's why you can't. It can be negative, but then when they look in the sputum or the feces, they're more likely to find it. So it's looking at different contexts, but you can also see why it's difficult. We haven't had a gold standard for being able to detect strongyloides. It is hard, but it's, yeah. What we've done at MeWatch, we've not seen it as we've seen it as a preventable chronic infectious disease, and we've had a strategy that manages it that way. We've learned, you know, we give deworming, still give albendazole to the kids, but we know that ivermectin is the best one. The other one, our lesson is that you need to give directly observed therapy. You can't assume by giving a script to someone that that person's then going to trust that, you know, it's a good medication. Directly observed therapy makes that difference. Follow up on strongyloides, and we know the way to know, have you eradicated it or not, or we just assume. So it's important to follow up. We have in Australia, this is about closing the gap on strongyloidiasis in remote Indigenous community. What we've done at MeWatch, we've included it in our adult health check, which is a national, there's a Medicare incentive item. It's for all ages, and it fits the criteria because it's a preventive health assessment to help ensure Aboriginal and Torres Strait Islander people receive primary health care matched to their needs by encouraging early detection, diagnosis and intervention for common and treatable conditions that cause morbidity and early mortality. Strongyloides meets this criteria in endemic communities. It might not be something that's done in mainstream, but certainly it meets that criteria and it should be recognised as a screening tool. However, we see it as testing, but it'd be nice to have it recognised as screening. The tool we've developed, because we've come a long way in the last couple of decades, we actually have electronic health records. Those electronic health records enable you to add that serology to the existing, it allows you to allow it to the existing tests when we're looking for STIs, we're looking for diabetes, we're looking for hepatitis B, is the cholesterol high? It's just included, so it's integrated. It's not dependent on whether the doctor knows about it or not. They discover it when they find, oh, what's this result? So we've been able to make a difference, and the KPIs we use in the Northern Territory for other conditions like anemia, we've adjusted that. So we can now say the number and proportion, resident Indigenous clients aged 15 and over have been tested for strongyloidiasis. What number and proportion of these were ever positive? They tested once, so you're finding out, you know, have we made a difference? What number and proportion of those tested were positive on their last serology test? That's a system, that a population health tool that we use for anemia, which is a problem in the territory. And this is one that I've adjusted for strongyloides. So, yep, it means if you don't look, you won't find. You can, you know, this was over a 4-year period, but you increase your coverage. You know, it increases. This clinic here only added it in at the beginning of 2015, but once you add it into the routine testing, you can see that, you know, it increases. So it's how do you increase it within a system. In terms of the proportion positive, we can see that it declines because you're following up the serology to see that they become negative. You don't just treat and ignore it as a chronic disease, you follow it through to see, have we made the difference? And so all of those show there is a difference. This is results of the difference we made in the ever positive. So that would have been the period prevalence in each community. That was the overall. Clinic A, you can see that all of them decreased, and Clinic D hadn't made such a big difference at that point in time, but you've got to be persistent. So this is the same report. We can now click a button and say, you know, ask the questions, and we can see at the end of 2020, that system continued. It didn't require, you know, external, it was a very efficient system, and reduced here. You can see this is about 4%. This is around about 5%. This one here was about 11%. This one's down at 10% overall. So we're making a difference. We're making a difference. We're able to decrease the human reservoir. We're still detecting new people, the 15-year-olds coming in, people visiting. They still need to be tested. So it's an ongoing process. It's integrated into our routines in our clinics, and we are making a difference in this area. So we can see, yes, we've got a primary healthcare strategy for measuring. Our goal is to close the gap on strongyloidiasis in endemic communities. We've got a system that works. It's sustainable and it's cost effective because it's integrated. It's integrated into our primary healthcare systems. Noting I'm the GP, so that's my sphere of influence. As GPs, that's our sphere of influence. It works, and this is a real world of endemic communities. We've also, just adding in, we know we've updated the life cycle, so we've addressed that myth about they'll only get it again. By reducing the human reservoir will make that difference. And then we do have a resource for GPs. If anyone, we used to get lots of queries coming over emails, and what we have now is a resource for GPs. So when we have that, we send out the resource, chronic strongyloidiasis, don't look and you won't find, and that gives information for patients to take to their GPs to actually, you know, follow the guidelines. Limitations, ours is looking at adults, and most infect are actually in the adults. We're seeing it less in children, but children we're not suitable for serology testing. There is a point of care testing that was developed but hasn't been followed through. That would be fantastic to have a point of care testing, just the finger prick and being able to tell where people are at that point in time. But otherwise it's sending away to laboratories. Now, our work has addressed the human reservoir. We haven't looked at the environmental health transmission. We haven't got it down to zero. To get it to zero, to actually eliminate it in remote Indigenous communities, where it's endemic, we actually need an environmental health as well. It needs a One Health approach, and that's the environmental health response. If it's notifiable, we can identify hotspots. We can say, where are that child, you know, a 5-year-old, why is someone in with a life-threatening condition having to be evacuated to a hospital? Well, who have they got it from? We do contact tracing. We've got a first world public health system. We can identify those hotspots, and then you can bring in your public health response. The public health response usually goes to primary health care. It says, you've got a condition, what can you do to help and what can you do to follow up? But we also need the environmental health team on board. So if you go and visit a home, and this is a case from 2012, we're in a very remote area. Everyone has, most people have access to toilets. Everyone who's on board in this meeting can be grateful for the first world sanitation facilities that we have. This was visiting a chronic disease patient, and I asked, I just asked the question, have you got any problems with your toilets? That's an environmental health question when you visit a home. She crossed her arms and she was frustrated, and she said, I had a blocked toilet. I asked for it to be fixed and they took it away. I said, what? Can I take a photo? Can I share that photo? Now, I don't know where else in Australia that would be an acceptable response. So if you don't go if you don't engage with environmental health officers, if we don't engage with, what's happening and listening to find out what the issues are, very hard to do. Anyway, the question is, would anyone else accept that as a response? It took 4 months, and the result from that was that it took 4 months. There was a second toilet, so maybe there was an assumption that the other members of the family could all use the same one. So anyway, that's an indictment. But 4 months later, she does have a new toilet. And that's the sort of why you need environmental health officers to be able to say, have you got any challenges? Is the sewage system working? Because out of sight, out of mind. Okay, so where are we at? National Strongyloides Working Group, these have been goals for a long time. We're 20 years in. We are now Strongyloides Australia Incorporated. Our goals are, the most logical one to make a difference is to make strongyloidiasis a nationally notifiable disease. It fits all the criteria. We've had a letter to the MJA recommending it. It's been put to, there's been a paper written as well, answering all the criteria, including that what it would do is close the gap on strongyloidiasis in remote Indigenous communities, and it's to identify hotspots and implement prevention and control programs. This is a partnership. We do this together. There's a saying up here about working together, and that's what we do. We have to, it's just the only way to work, and not just across our communities, but it's across all communities, and it's across our different disciplines, because different disciplines have something to contribute. Just want to say that the inspiration has been the strength, resilience of Yolngu colleagues. As a GP, it's been my responsibility to take this as far as I can. Miwok Aboriginal Health Corporation, the board, the staff, community members, James Cook University, without Rick Spear and his support along the way, everyone. Sorry. Yeah. We obviously all acknowledge Rick. He's inspired many of us to go down this path and to support us in the path that we take. There's been people at this group at JCU, the National Strongyloides Working Group, absolutely amazing group. And if you join, anyone else who wants to join, You know, we're passionate about what we do. It's a fantastic group of people all wanting to make a positive difference. ANU, Darren, thank you, and Toby for trying to get me through the challenges. We thought we'd sorted it last night, but anyway, we're getting there. And all attending this meeting, I want to say thank you to everyone who's attending this meeting for your interest. So there's one more message from me. I was very fortunate this year, very honoured and humbled to be given the award of NT Australian of the Year for the Northern Territory. And it wasn't, as I've seen, it wasn't about me, because I'm one of many other GPs that are out there working now. You know, they're, you know, passionate about what we do. It was really about this cause that we're on and how do we take it further. So Dr. Amaja Marika, I can say her name now, it was her sister who passed away in 1999 from disseminated strongyloidiasis, and we dedicate each workshop to her sister. Amaja was awarded the NT Australian of the Year in 2007. Her shirt, you can see a beautiful black glowing face, just this wonderful, welcoming, you know, humble yet proud woman, strong woman. She's got thanks. The thanks is for Sorry Day. The thanks is for Sorry Day. And so what's Australia's, you know, response? She was thanking Australians for saying sorry. We've still got a lot more work to do in that space. When I told her the story, about her sister, she was still grieving for her sister in 2000 when I told her the story, and we went over it, and I said how we are now introducing ivermectin and we were making a difference. And the work she was doing, she was encouraging us. And her words to me, and they're the words that I leave with everyone in this group. Her words to me were, "Let not her death be in vain." Thank you.
Thanks, Wendy, for that fabulous talk. Really inspiring words there, especially at the end. So thank you very much. So after this, we're going to move to a panel discussion, which Professor Judd will moderate. Before then, we have some polls for people to answer. There's two questions that we want to put up now, just for people to answer, and that is a good way to come into the panel discussion. So the first question is, did you know that strongyloidiasis is endemic in Australia? So we've got our answers coming in now. It's still coming through. Anyone?
Oh, they say it cannot vote.
Yeah.
Oh, we can't vote.
We can't vote.
Oh, we can't vote.
We're almost there.
Hopefully we should already know, right?
Knowing where it is endemic. Oh, they already know the answer. Aileen, thank you. Aileen has a story to tell about Kuranda. She would be amazing as well. We've got these people that can tell the stories.
So the results are in, and 70% knew that strongyloides is endemic in Australia. So that's good. We've got some awareness. Fantastic that people know. So we'll move on to the second question, Toby. Okay. Question 2. How many people are infected with strongyloides in the Northern Territory? Almost there. Okay, so we've got 3% saying 0.5%, 55% saying 30%, 6% saying 80%, and 35% saying that we don't know. Well, Wendy, I think the answer, do you want to reveal what you think the answer might be?
Well, across the Northern Territory, the bottom line is we don't know.
Exactly.
We don't know what our current status is, because if it's not being tested or not being measured, we don't know.
Yeah.
But we know we have, higher rates than probably other places. Jenni might want to speak to that one.
Yes, the data that I had for the map, there were 15% of the people tested in 2012 to 2016 in the Northern Territory, and that was the highest percentage. Looking at the number per 100,000, it was 480 per 100,000 in the Northern Territory, compared with the other states, 34 in South Australia and around about 30 in Queensland and Western Australia. So you can see the Northern Territory stands out.
Great, thank you. So we have 2 more poll questions that we'll have later on, but we'll now move into the panel discussion. So I'll hand over to Professor Judd, who can introduce the panelists and then start questions. Now, in this session, Jenni will ask some questions of the panel, but we also encourage the audience to put some questions into the Q&A that we can answer as a panel as well. We want to have this as an interactive panel, not just a talk fest between the panel members. So we want to interact with the participants. So I'll hand over now to Jenni.
Thank you very much, Darren. Morning, everyone. I'd just like to first of all ask the panel members to briefly introduce themselves, so you know who you're talking with in this instance. Can we start with Siddharth?
Thank you very much, Jenni, for inviting me on the panel. My name is Siddharth Mahanti, and I'm an infectious disease specialist and an associate professor at University of Melbourne in the Doherty Institute. My interest in Strongyloides stems from my long-term interest in immunology of worms, and I just think Strongyloides is understudied and a fascinating system to investigate and to research.
Thank you, Siddharth.
I'll stop there. Yeah.
Over to Jenni Shields.
Well, you already know that I've been collecting data from pathology laboratories to develop a map of Strongyloides in Australia. So I think I've spent a little bit of time in northeast Arnhem Land working with Yolngu people, and particularly in developing educational materials that they could understand about Strongyloides and about some other health issues as well. Thank you.
Thanks, Jenni. Richard?
Thanks, Jenni, and thanks for inviting me to be a part of the panel. I'm Dr. Richard Bradbury. I'm a senior lecturer at Federation University in Melbourne. I previously was the head of the parasite diagnostic lab at the CDC in America. And prior to that, I've worked in Australia, both in diagnostics and academia. The late Rick Spear, who was mentioned earlier, was one of my great mentors in my career and introduced me to Strongyloides, which I've since pursued as a research interest. So that's my background.
Thanks, Richard. Over to you, Catherine.
So I'm Dr. Catherine Borden, and I am a parasitologist based at QIMR Berghofer in Brisbane. So mostly I work on Helminth parasites and schistosoma, which you can see behind me there. But I became interested in Strongyloides a few years ago, looking at some of the case studies coming out written by Lloyd Einsfordel, who works in the Alice Springs area of the Northern Territory, and looking at the deaths that were being caused by infection with Strongyloides, and that's where my interest really started.
Thanks, Catherine. And you've met Wendy before. Wendy, do you want to do a quick hello?
Hello.
Okay, I'll hand over to Darren then.
Hi, I'm Darren Gray. I'm an infectious disease epidemiologist at the ANU, and I've been working for many, many years now on neglected tropical diseases, and particularly in the Asia Pacific region. But in recent times, I've been more aware of these NTDs in Australia, particularly Strongyloides, and how they really shouldn't be here, and so I've sort of joined this group and really trying to help push the agenda of Strongyloides elimination in Australia, and certainly with the One Health approach. I'm a big advocate of that. Thanks.
Thanks, Darren. Over to you, Kirsten, sorry.
My name is Kirsten Ross. I'm here at Flinders University. My area of interest is in environmental health, so looking at where Strongyloides is actually living, so specifically focusing on dogs, flies and wastewater.
And I'm sorry, I didn't introduce myself. I'm Jenni Judd, previously a professor of health promotion, although that's my passion. I'm now working as a professorial research fellow with the First Nations Academy, which is an academy of Indigenous students, First Nations students at CQ University. And my interest in Strongyloides came from, you heard it, Emeritus Rick Spear. Professor Rick Spear. He introduced me to this in 2007, so I wasn't in the original group of people, but I became passionate about prevention, and especially that we've got it in Indigenous communities, and I just think it's a human right that those peoples should not be more affected than anybody else in this country. So on the first question then, what are the barriers and challenges to prevention of Strongyloides in Australia? Just to get the panel started, who would like to go first?
I'm happy to have a quick crack. I would argue, given what we've seen in response to COVID, that it's probably mostly political will. Given that we can really readily mount a massive public health response if we want to. Yeah, my view on this has changed substantially as I've watched our public health response in Australia to COVID unfold.
Thanks, Kirsten.
Could I, talking about barriers, could I talk about that children aren't being tested, and so children with Strongyloides aren't being treated for Strongyloides, and I think that's a diagnostic problem. Need for point of care tests so that they have got a health system where they're monitored and they're given medicine for hookworm, but not for Strongyloides.
Siddharth, I saw your hand go up.
I'm muting you. Sorry. Yeah. Actually, that's. I think all those points are very good, just made now. But in terms of barriers, one of the big barriers that I see is lack of knowledge of prevalence. I think that poll question really brought this to the forefront, that we don't know how prevalent it is, and without that knowledge, it's hard to even move any political will. I think that's the first step we need to do.
Richard.
Just following on from Siddhartha's comment about lack of knowledge of prevalence, I agree that's a major problem, that there is a lack of understanding of just how common this is. There's also an issue with lack of education in medical circles and pathology circles and such like about parasitic diseases generally, but particularly strongyloidiasis. So there's not a lot of education of this within medical programs. A lot of doctors are unaware of strongyloides as a potential diagnosis, and often there will be many other avenues followed, and sometimes it'll be missed as a consequence. So it's the tip of the iceberg is what we see diagnosed, in my opinion. I'll
just follow on from what Richard said. Steve Mui is a clinician who works in Melbourne. He couldn't join us today, but the hospital he works at, they have guidelines to test people for strongyloides if they're coming from an at-risk background, particularly if they're about to be immunosuppressed. But he's even said that sometimes that just doesn't happen. The doctors don't do it, they forget, or they don't think it's important. So, it's really important to try and get the message out there that, it does matter and it is important.
Yeah, Catherine, just on that point, I think that's a very good strategy to bring to the forefront, because what he found was that only 1/3 of the times the tests are ordered when all the criteria are met for strongyloides to be screened for. So it's really a lack of awareness.
Yeah. Thank you, Siddharth. Darren?
Yeah, I mean, in terms of certainly the challenges, the diagnostics, we don't have a gold standard diagnostic test. I think that leads a little bit into the fact that we don't really know what the true burden of strongyloides really is. Obviously, there's the need for it to be notifiable. There's the political will to be able to test, but then we need to have a good test that's readily used, and particularly a point of care test, given that this disease is so common in remote communities. So this is a disease in remote areas. So there's big challenges around that. So a point of care test would be critical. And of course, we talk about the underlying conditions, just housing conditions, lack of sanitation, lack of access to water. I mean, these are major challenges. And I think the rurality of the cases is a challenge as well.
Thanks, Darren. I note there's some live questions in the chat for a couple of people to answer. Wendy, are you testing and treating kids in practice?
Yeah, so kids are treated with albendazole, and it's not just one dose, it's 3 doses of albendazole. Ivermectin hasn't been introduced. It could be used from 5-year-old. We have had a person on our panel, a paediatrician from Alice Springs, who was absolutely passionate about it. And certainly one of her cases was a child that wasn't responding, failure to thrive, needing to be taken away from the mother because the child wasn't growing, and putting it into, and then when she gave the child, who was under 5, gave the child ivermectin, the child responded and didn't need to be taken away from its mother. So there are multiple factors that are involved there. Again, if once you start identifying where those cases are, and laboratory notification is the easiest way, then you can say, if there's a child, what's happening? You do contact tracing. You've got a positive case, you do contact trace. They've got it from somewhere, and they need to find out who the humans are, and then and we've got strategies that will work. We've got diagnostics. We can improve the diagnostic. The diagnostics we've got serology is the same serology test that was developed for the ex-POWs when they had it 40 years later. We're still using the same test, and it's the same cutoff that was diagnosed, that was used back then. But yes, so if a point of care test was being done, again, you'd be measuring the immune response. So with a child, it's more likely to be their first episode, and that's saying it's a new case, an incident.
One more question for you, Wendy. It came from Harrison Shanley. Thank you for the fantastic talk. Apologies if you've already covered. Has there been any evidence of resistance development to repeated treatments of ivermectin and or albendazole in strongyloides? And if so, is this the current cause for concern for long-term strongyloides infection? I mean, I think Wendy, you go first, and if there's anybody else who wants to pop in for the answer on that one, please do.
I have seen a paper that refers to resistance on a case. So there's almost no research being done on strongyloides. It doesn't rate, you know, when in grants for doing research. So there are a lot of questions we need to ask. We have an effective treatment. People need to have more, but, you know, there's questions around absorption. Is there resistance, or is it, you know, we don't know. But there's one important lady, and she said, you know, resistance follows like a shadow with treatment. So, you know, we need to be able to be getting on top of it and using it, and then asking some of those questions.
Does anybody else want to pop in about the resistance question?
Yeah, we've seen strongyloides resistance in the horse and sheep variants of strongyloides species. Now, they're not the same as strongyloides stercoralis, but it indicates that with repeated doses, it's going to happen. Like Wendy says, it's likely to be happening.
I would add to that there's simply no research being done. We're not looking for it. We don't know. There certainly are cases of reactivation occur where people are treated and then some months later they seem to get disease. Is it reinfection? Is it reactivation? Hard to tell. But no one has done any research on this, and it should be done. Certainly there's resistance in the human hookworms, which are not the same, but it does demonstrate that resistance can occur in human soil-transmitted helminth infections.
Barbara Story has a couple of questions. How many treatments of ivermectin is necessary and safe to get to zero infection?
So I'll take that one. In terms of safety, the case I gave was the one from was Potter, 2013, a case in a Royal Darwin hospital. This ivermectin seen as being actually very safe. It paralyzes the parasite, it doesn't actually kill it. And that story, when you read the paper, shows, you know, he's this 19-year-old who's showing larvae in the sputum, and they kept giving over and above the amount of ivermectin to stop the larvae moving. So when the larvae stopped moving, they felt they were on top of it. So it's a little bit of, you know, how much of a dose do you need of something as well. I mean, there's so many factors that we need to be able to ask the questions. And if we're not identifying the cases, we're not able to ask those questions. So, and Australia is in a position to, you know, if we prioritise it as an area that does need more research, we can start to answer those questions and give more, you know, have more input into that.
Sorry, Siddharth.
Sorry, can I just add a comment? That's Wendy, you've covered the subject really well, but just in terms of safety, there's a huge experience with ivermectin in Africa, because it's been used for more than 30 years now for treatment of onchocerciasis, river blindness, where they give repeated treatments over many years, and there's not been a danger signal in terms of drug toxicity in any of those. And the dose we give for treatment of strongyloides is essentially two doses a week apart or 2 weeks apart. So it's not an ongoing exposure to the ivermectin. I think safety is not that much of an issue. It's more a question of how effective it is. As you said, it has a differential killing ability in adults, worms versus larvae. It's less effective against the larvae. And that's the reason for doing the second treatment. So the larvae that have matured are then more susceptible for the second round of treatment.
Another question from Simone Reynolds. How do communities perceive Strongyloides disease? Scabies is normalized and has great stigma. Is it the same in communities? So that's a Strongyloides question. How do communities perceive it? Jenni Shields? You're on mute.
I missed the first question.
How do communities perceive Strongyloides disease? Is it like scabies where they think it's kind of normalized and has great stigma? Is it the same in communities with Strongyloides?
The problem with Strongyloides is that it's invisible. People obviously don't know that they've got Strongyloides, except in a few places where we've done some community education. So I suppose probably the symptoms of Strongyloides have probably become normalised, but it's not really in the same category as scabies, where that's become normalised, even though it's a nasty thing to have, even without the secondary infections.
Thanks. How common is co-infection with cohabiting people in households with good sanitation? That's another question from Barbara Story.
So with David Grove, Professor David Grove did work on the ex-POWs when they came back, and they had recurrent rashes and had recurrent diarrhea, and those were the ex-POW, they'd been in areas where, so many had been infected. There was uncertainty as to whether they were transmitting it, and particularly as whether it could even be sexually transmitted. And the studies that they did were that no, they weren't being, it wasn't transmitted from person to person in that context. But if you have areas of poor sanitation, and if you've got 17 people in a house and you've got one toilet, then what people are inclined to do is, if people want to go at the same time, people would look to find what they would see at a discrete place outside to go to the toilet. So it's
small problem.
So where there's adequate sanitation facilities, doesn't seem to be.
So another interesting question was, how can you reliably test if infection has reached 0?
Not an easy one, because one remaining parasite is possible to one of those, amazingly persistent, resilient females, is possible to be reinfected. As we said, the dower phase, there might only be, it looks like an old spent female, but give it some corticosteroids and that can potentially start things again. So sometimes with treatment, we don't know if it's recrudescence as well. But Richard's got his hand up, so I'll let him.
And so's Catherine, I think. Oh no.
as far as testing in a population where it's been eradicated or near eradication, the serology is unusual for Strongyloides. Normally when you do infectious disease serology, a positive means current or past infection. With serology for Strongyloides, it's quite strange, compared to most infectious disease serology, because after treatment, within about 12 to 18 months, the majority of patients revert to seronegative. What that means is serology reflects current or recent infection. So I've been involved in surveys in the southern states of the US where we've used serology as a method of screening a population where it's likely eradicated to see if there's residual infection. I would put a caveat on it that there are occasions when people are seronegative but are still infected, and we see the larvae in their feces, or we culture the larvae from their feces. So it does occur, particularly in immunocompromised patients, that they can have negative serology while still be infected. But if you're asking about the way to screen a population to confirm eradication, serology tests probably be ideal. I don't know if Siddhartha has any further comment on that.
Yeah, so I think you made the most important point, that the serology is unusual in that it goes to negative, but it's not very sensitive at very low levels of infection. And that's a problem with all the diagnostic tests for strongyloides. I think even the PCR is not very sensitive when there's very, very low levels of infection. So to directly answer the question, it's probably impossible to tell that there's no worms left in a particular person after treatment.
I've got a couple of interesting questions here. One around what sort of figures are available for non-Indigenous populations. Is it also under identified outside the NT? Are these populations which may have been exposed while travelling and with access to better sanitation likely to spread it outside endemic areas? That's from Rachel Gore.
I can start on that if you like. The answer is yes, it has been identified outside of the NT. I'll let Jenni perhaps speak to that. She's done the most work on its prevalence throughout Australia. There was a recent study in South Australia of Vietnam veterans which found that 12% of them were still seropositive, which indicates they are infected with Strongyloides. Refugees, returned travellers and immigrants are also a group that can have a lot of infection. We don't know about groups like the grey nomads, the sort of retirees who are travelling around Australia and Winnebagos. I'm sure there would be infection amongst them. So it does occur outside of remote communities. We do get cases in Townsville and places like that. We get cases much, much further south. And there are particular groups such as veterans and other marginalised communities, refugees, immigrants, etc., who are particularly at risk. Jenni, do you, or Kirsten, do you have any more to add to that?
Well, as far as the returned international travellers, I think the travel doctors are very aware of Strongyloides, and in the map, the Canberra, there was a fairly large number of people with Strongyloides in Canberra, and my guess is that they represented returned international travellers, maybe ADF people. Yeah, I think that's basically all I need to say.
Yeah.
But with the data for the map, I'm afraid we didn't know the ethnicity of the people involved. So we're really guessing that because there's lots of Aboriginal people in Northern Australia, then that it was due in that area, it was probably mostly due to Aboriginal people who picked it up in the communities, and further south that it's probably mostly due to returned international travellers or refugees who caught it overseas.
I need to just clarify what we mean by further south. So here we're talking Sydney, Melbourne, etc. But there certainly have been autochthonous infections in the Northern Rivers region of New South Wales and in desert regions of South Australia. So,
and also in Western Australia in Kalgoorlie.
Yeah, so it's not limited to the tropical north. It's quite far south in Australia, much further south than most people are aware of.
The World Gastroenterological Society organisation, one of their quotes is that a patient with strongyloides can present at any consult room anywhere in the world. Yeah. And one of the more recent cases related to Moscow. So whether that's someone, you're looking at, the factors where it can transmit, and the fact that people are carrying it for a lifetime. It loves to live in us, and we travel.
That's a really important point. We have cases of infection that have been retained for up to 60 years in the literature. So it was a big problem in Far East prisoners of war from World War II, right up until the 1990s. Someone who, for instance, might have been a child in an endemic region might have spent only a month or two in, for instance, a remote part of Northern Australia as a child and has lived in Tasmania for the rest of their life, could be in their 60s and still have strongyloidiasis if they haven't been treated at some point. So it's not something where you're going to, well, you've been away from an endemic area for a long time, or you travelled on a holiday to Asia when you were 21, but you're now 54. You still have to consider strongyloides in that circumstance.
I have one more question relating to doctors. Robin Weeding's got a question about many Australian doctors still diagnose severe cases of strongyloides, patient reported, as being a mental health issue. How can we change this attitude, please?
I can tell a story about this. There was a fellow in Tasmania who, in the 90s, he was a former prisoner of war in the Burma-Thailand Railway, and he turned up to his doctor and said, "I've got worms crawling under my skin." The doctor immediately decided that he had delusional parasitosis, sent him for a psychiatric consult, and he was getting psychiatric consults for several years until he was in hospital with had diarrhea in hospital. He was in hospital for a totally other reason. They did a fecal screen on him, and it was full of Strongyloides larvae, which he'd retained for the previous 40 years. There's a lot of cases. Delusional parasitosis is a thing. It's a real thing. We do get a lot of, anyone who's involved in parasitology comes across these people. But it's very important not to put someone in the delusional parasitosis bucket without doing proper investigation first. And I think it's also important to recognise that eosinophilia is intermittent in strongyloidiasis. So you may have someone who has current strongyloides infection but has a normal eosinophil count. So the full blood count for eosinophils is insufficient to exclude parasitic infection in those patients. So it is really important that we don't put people into the bucket of delusional parasitosis without performing a thorough investigation to confirm that they really don't have a parasitic infection first.
Did anybody else want to add to that? There's one more. Sorry.
Maybe I can add just a comment to that. While it is true that strongyloides gets missed a lot in the general population, and maybe sometimes even in immigrants, it's not thought of. But with people who come with symptoms of delusional parasitosis are almost always screened and checked for strongyloides if they come to any of the regular infectious disease routes of referral. So this should not be I don't want to a misconception to be spread that strongyloides is missed because delusional parasitosis becomes to the forefront when somebody comes with these types of symptoms. We always screen for strongyloides as the first step.
I have a couple of questions, notes and questions around dogs. So Vito Kalila thought it was a terrific talk, Wendy, but a small note. Some of the haplotypes in dogs are shared with humans. Dogs are untreated and not routinely screened for parasites in these areas, but we know from few studies that strongyloides occurs in high prevalence in this domestic animal species in the Asia Pacific. One health approach that includes MDA in dogs would probably lead to a sustained control of this parasite. I'll just leave that there, and then I'll add this other question from Brandon Lee. Thanks for the fantastic talk. I was interested in hearing your thoughts on how important is the role of dogs in transmission of S. stercoralis to humans. How would you suggest to control Strongyloides stercoralis in dogs? So Kirsten, Richard, there's a couple of you there really interested in this area. Can you have a crack at those, please?
Sure. The jury's still out as to whether there can be dog-human or human-dog transfer. Certainly there's evidence. I think that it's probably likely. Having said that, it's quite, the evidence could be put aside as perhaps a dog eating a nappy. Having said that, if you're undertaking any sort of screen or treating program for humans, do the dogs at the same time. That's my advice. While we don't know definitively, let's apply this precautionary approach because it can only do the dogs good to be treated. And if we don't really have that transmission, then that doesn't necessarily matter. But if we do, then we might potentially be stopping it at the dog source. Richard, over to you.
Yep, I think you've said most of what I'd say about that. Vito's absolutely correct. There are haplotypes which are shared. So haplotypes are a type of DNA cluster which are shared between humans and dogs. So it shows that at least those are very, very, very similar. Dogs also have another strain of Strongyloides stercoralis, which seems not to infect humans. So it's very hard to work this out unless we do further work to work out, well, how common is the one that's found in humans and dogs and the one that's found in dogs only. We need to do more work. Kirsten's group and working with my group at CDC did a little bit of work on that, and certainly found that both are present in Northern Australia. I think we need to get better genotyping techniques to definitively answer the question. There were a lot of experiments performed between the 1920s and 1950s of trying to infect dogs with human Strongyloides. In most cases it failed, but in one case it did take, and the dog, you know, obviously there was interchange of infection. There's only one case report of someone being infected from a dog almost definitively, but perhaps that's being missed. The simple answer is we don't know for sure, but I agree with Kirsten and Vito, it's very likely that dogs are a reservoir. And I think we do need to take a One Health approach, even as a precautionary thing until the research can be done with better genotyping techniques to demonstrate definitively whether it's coming from dogs or not. But I think it likely is in Australia at least.
Yeah, just to add in that, you know, treatment of dogs as part of this integrated approach, you know, is the key. So, you know, we want to have the treatment of dogs, treatment of people, improving the housing conditions, providing access to water and sanitation, and that holistic approach is what we need to lead to sustainable control and elimination.
And of course, treating the dogs will also help with some of the zoonotic hookworm species as well that are in dogs, which have already been shown to be in Australia as well. So it's really nothing too bad that can happen to the dog if you just treat it just in case.
And healthy dogs, healthy communities is how Aboriginal mob feel, because their dogs are really important to them. Wendy.
Yeah, so it just brings back a quote from an Aboriginal lady. I said, well, what about treating the dogs? And she said, they're part of the family. Of course we treat the dogs. You know, healthy dogs, healthy community. And One Health has humans taking a part, the other living animals, which include dogs as a part, and environmental health. And that whole connection, if we just see things from a health side, we're taking a very limited perspective. It's a very broad area. Yeah.
And just another question up on the post is, can Strongyloides cause an indentation in the stomach wall seen on gastroscopy? All tests negative. Barbara Story asked that question. Does anybody want to answer?
Yeah, I can give a general. I'm not exactly sure what they're talking about in this. What they're referring to is the
indentation in the stomach wall.
Well, I assume they're talking about gastroscopy. In gastroscopy,
Yes.
during gastroscopy, it's noticed on the surface of the intestinal mucosa, and the answer is that's true. You can see abnormal sort of variations of the mucosa that can look like indentations or outpouchings. Usually, it's not in the stomach so much as further down in the intestines. And biopsy will definitely reveal the larvae. If an abnormal area is seen in biopsy, it's a way of diagnosing it for sure.
Okay, so I haven't got any more questions from the participants at this stage, but I have an interesting question. So what's currently being done to combat strongyloiditis in Australia? So anybody can answer this one from their perspective, because we're very lucky we've got broad perspectives here.
Not much, other than Wendy's great work. In a simple, Wendy, you're on mute.
Sorry, there are people around, and there was a paper that early on James McCarthy wrote, and he referred to the, you know, bringing on the paediatricians, bringing on the public health team, bringing on the infectious disease, and he referred to the enthusiasts, and it's when we're doing things what seem to be a little bit in isolation, and this is why we need it made notifiable nationally to raise that awareness. But I know Aileen Traves is on board. Aileen's done work in Kuranda. We know Russell Hayes has done work, following one of the nurses in Western Australia presented in WA, and she told her story. She was about to be given corticosteroids and she'd actually been infected. And they've done, great work in reducing there. So we've got systems that we know we can work, population health approach that can work. And we know that, there's work that's been done with refugees. It's how do we bring it into a bigger population health system, because Woorabinda did work. Woorabinda did a fantastic system. It was identified that it was a problem, and that was after 2 deaths, a child and then a man who had a meningioma and went to PA Hospital 2004 and was given corticosteroids. So he didn't get a chance to go to surgery because they were trying to fight, how do we treat the Strongyloides? So I think it's about awareness, and those that are aware will look. But even amongst the oncologists, we've got a patient who was going over for cancer treatment and said, I think I'm meant to be treated for, can you treat me for Strongyloides? Oh, okay. Oh, you are meant to be treated. So we're dealing with a lot of low awareness. We've had a lot of myths in the past, that it lives in the environment indefinitely. That serology doesn't, once you've got it, the serology stays there. We know it, it's unusual, but if you haven't got Strongyloides, it will, the serology, can go to negative, and that's a marker of cure. So it's we've got the challenges in raising awareness. And I think everyone who's on here today, being able to just raise that awareness, even asking around the people you work with. Have you heard of Strongyloides? Ivermectin came up in COVID-19, as is ivermectin going to make a difference with COVID-19? And then it was poo-hooed, it's only for dogs, it's only for horses, or, or for scabies. Strongyloides didn't get a mention. So if someone, and I don't know what the outcome's going to be with the ivermectin trials regarding COVID-19, but I do know if someone's got COVID-19 and they're given dexamethasone, you're not going to be diagnosing that disseminated strongyloiditis when they're in ICU, because they're unlikely to be taking the sputum specimen to see if they've got larvae in the sputum. It's a comorbidity. And I'm sure in other developing countries in South America, they'll be giving, if they're treating COVID cases, it'll be prophylactic ivermectin, not for COVID, but it'll be prophylactic ivermectin to make sure they don't develop disseminated strongyloiditis affecting the lungs.
Just adding on to the dog question from Brandon Lee, how do you control stercoralis in dogs? Richard, did we answer that? Ivermectin, is it?
Yep. So it's
yeah, sorry, go on, Kirsten.
No, you're probably more of an expert.
No, you guys, you probably know more than I do on that one. Tell me.
Yeah, so the common treatment is ivermectin, and AMREC's been doing a fabulous job in the Territory and in northern Queensland and WA, where they have regular treatment of the dogs. I think one of the downsides of COVID has been that these dogs haven't been receiving those regular treatments that they've been getting. So it'll be interesting to see whether or not we do perhaps see an increase in strongyloiditis cases in humans as a result, because there has been a downturn in the number of vet visits going to these communities. That might provide some evidence, but that's just a guess.
And just another interesting question from Michelle Castelletto. From a historical perspective, how did awareness of strongyloiditis emerge in Australia? Do we know the answer to that?
We probably don't know the answer, but it might be a good place to plug our paper that we published as a group earlier this year, HTLV and strongyloiditis in Australia, which we put together. It's based on what has been published in the literature, so whether or not that's when it was first sort of came to awareness in Australia, but the earliest published cases are from the 1970s and the 1980s, and continuing on from there. So it's kind of, you know, an ongoing awareness. Awareness is still, you know, pretty low, as we've just sort of discussed, everywhere, but you know, it's been around and noticed since at least the 1970s.
It was reported in 1918, I think, as part of the hookworm surveys which were being done in North Queensland.
Yeah, I think there's like a gap sometimes with the parasites in Australia. It's like very, very early, and then there's nothing for a few decades, and then somebody must get interested again.
Yeah. I think at that time its significance wasn't really recognised back then.
So just to add, the 1980s were when it was being recognised in the XPOWs in different countries. And that seems to be the time that they realised it wasn't just a case of reinfective. Oh, they're only getting reinfected. There was a realisation that there was an auto-infective cycle. So that was important. The French recognised it 1876 with microscopy in their naval personnel coming back, both disseminated in the earlier phases. But in terms of, I'll just throw in the oldest case. What's the oldest case? A trivia question. The oldest case of strongyloidiasis. Catherine has schistosomiasis sitting behind her. The oldest case that we know of is an Egyptian mummy by the name of Asru, A-S-R-U, and so a portion of her intestines were rehydrated and identified both schistosomiasis, called Bilharzia then, and strongyloidiasis. So it's been around a very long time. As we know, it's a bit evasive. It doesn't really want to be discovered. But it's a challenge, and we need to do what we need to do to you know, discover more about it and be able to run with particular programs. I just want to add, because it hasn't been added in at the moment, and it follows the question on resistance to ivermectin. There is work that's happening at the moment with moxidectin. Moxidectin is the same family, so to speak, and moxidectin has a longer half-life. It stays in the system for longer. So at the moment they're trialling it with scabies, because we know with scabies they need the second dose because it might kill the adult scabies, but not the eggs that are still waiting to hatch. And that keeps it for, may help with not having to give that second dose. So moxidectin is there on the horizon, and again we've got Michael Sullivan got the Victorian Australian of the Year award some years ago, was his work on moxidectin. So we've got people that are passionate about it, want to be doing something, taking things forward. It's just how do we, bring it together. So, yeah. Again, make it notifiable, and it raises awareness. How do you deal with a neglected disease? Well, it's on the notifiable list. We need to be doing something, and that's why it's probably the biggest goal if we could make that happen. We've got the technologies. It's just a national database.
Okay, Siddharth.
Unmute, yeah. Maybe this is also a good point, good time to just mention the WHO program for elimination of strongyloides, which has become part of their agenda now to try and eliminate strongyloides by I think it's by 2030, which is a very optimistic timeline. But that could be an important program to liaise with if we're going to be part of the world where it's eliminated.
Yeah.
Okay, so the last part of this is really moving forward. As we all said, part of the reason we gathered together today was to try and work out what our best moves forward are. So I'm going to leave that open to you. what are the things that we can do as a group to work on moving or ending strongyloides in Australia? Don't jump with.
I think, well, I think, you know, as Wendy's been saying, the making strongyloides notifiable is a very good first step in sort of raising the awareness and identifying the areas. But then we really need to continue the much needed research that, you know, once we've identified where these endemic areas are, we need then to be able to go in there with a solid One Health plan to eliminate strongyloides. And, you know, we need to do some research into what's the, you know, the best combination of interventions. We need to, you know, refine the diagnostics, you know, such that we can, you know, such that we have point of care diagnostics, for example, get that evidence base, because it's important that if we want to have some kind of nationally coordinated public health response, we need to have an evidence base behind that. So I think, you know, one of the big things is making it notifiable, and at the same time, start developing, generating the evidence base for the public health response that can be then rolled out accordingly.
And then I'd also add in the health education, not only of the people in the affected areas, but obviously the physicians who are going to be working in affected areas or who are going to be treating you know, immigrants and refugees that may potentially be infected as well.
Anybody else want to add any of those things? I can pitch my prevention side of things.
Prevention.
Jenni.
Yeah, I think one of the strange things about the approach to strongyloides in Australia is that there is a protocol, recognised protocol for testing and treating immigrants and refugees for strongyloides, but there isn't one for identifying and testing Aboriginal people for strongyloides. And the actual amount, you know, the prevalence rates in Aboriginal communities is actually higher, quite a lot higher than it is in refugees. And earlier on, you were talking about people who have been treating, you know, had a program for testing and treating for strongyloides. And there have been a few, but the problem is that they're not coordinated. It just depends on some person in one area to spearhead something. So, like for instance, in the Kimberley, that work that Russell Hayes did in the East Kimberley, he's now their expert on strongyloides, and there's been a lot of work done in the Kimberley for testing and treating strongyloides. And also in Northwest Queensland, Len Van Ingen, who's been associated with this group, he did he was there temporarily, and a large number of people, it was about 40% of actually of those people he tested and treated had strongyloides. So there've been little patches. Thanks.
We have a question in the chat around, can I ask about the pathology testing for Indigenous people? How is it performed?
You want me to answer that? It's variable, it depends on which laboratory it goes to. A lot of the labs are moving to PCR, multiplex PCRs, some of which include some strongyloides, some of which don't. The traditional microscopy approach is only about 20% sensitive, so you miss about 80% of the cases. So it depends on which laboratory you go to, really. Some of them run PCRs, which, if done properly, are reasonably sensitive, somewhere in the region of 75% of cases are picked up, but some do serology. But once again, there's no unified approach either on what's the best diagnostic test. So the pathology labs do what the doctor requests. And if the doctor does not request, for instance, strongyloides serology, then they may not get that particular test. I'd like to see we also don't have a lot of information about the relative performance of a lot of the tests. A lot of the work on that has not been very well done. So we need to get better information on the relative performance of the test, and perhaps come up with some national guidelines for testing for strongyloides for pathology labs.
That's a good follow-on question from Ariel just there. Is it difficult to get the samples to the labs from remote areas? And the answer to that is yes, it can be. But I'm sure somebody else can answer that a bit more fully.
Most of the labs which are doing the parasitic screening are in capital cities. So Cairns does parasites, and so does Townsville at the public labs. But in the private labs, most of it's being done in the capital cities. What that means is that you can't, one of the most sensitive tests on feces is culture, but we can't do that because they'll be dead by the time they get there. So you really have to preserve the sample, or, you know, or it sits in, it may take 4 days to get to the lab, 3 to 4 days sometimes to get to the lab from a remote area. It's not ideal. So yeah, it is quite difficult. And as I said, the labs, just economies of scale, their parasitology testing is done in capital cities. It's not done out in the regional country labs any longer. And so, yeah, it takes a few days.
There's a question in the side trip, which is a personal one. And Wendy, perhaps you might be able to talk to Barbara about her question offline. It's a strongyloides question, you know, about personal symptoms that probably needs a personal answer.
Just in general, we do get, because people think, oh, could I have it? And it usually means, you know, what are those vague symptoms? Could they, you know, because it is non-specific. So strongyloides stercoralis, strongyloides really just falls into that differential. It's one, if it is that, then it's treatable. And so it's relatively straightforward. The paper was written pretty well for GPs, but it's very, very good for patients as well as an education tool. It hasn't changed in that time since we've written it. Is if you look it up under Page and Spear, but chronic strongyloidiasis, don't look and you won't find. And so what we advise, if someone's got personal, you know, they want to ask, you know, have a consult, taking that paper to the GP. I'm happy to be contacted by the GP, because they then know the full context for that person, and I'm very happy to be contacted to say, you know, give feedback on that and advice on, you know, how maybe someone's interpreting that serology. We had an ex-POW where the message was shared, and he wanted to come and visit me where I was, but it wasn't possible. And I liaised with his GP, and then we're able to go through, you know, that medical side, and, you know, able to do that management. So, but if it, that's the paper to be able to go to and take it along to the GP. The GP is able to say, yes, well, look, I can do this test, and then we'll see where things are going, or make contact with me.
I missed one from Ian. I know he had a question, and I see that Vito's answered him. Camera and Rebecca Traub are performing a study in dogs living in Aboriginal communities using MLs, and up to now there is no report of adverse effects. Following Wendy's comment on Moxie, we're also trialling moxidectin against strongy and hookworms in community dogs in Cambodia and prevention of infection in children. I agree with Wendy, Moxie has a longer plasma retention than ivermectin. That was just an added comment there. Do we want to do that poll, Darren?
Yeah, we'll just do one last poll before we finish up. So I'm going to launch this one. So do you think strongyloides should be notifiable? So we can answer this poll, and it's probably a good way to finish off our seminar today. So 100% fabulous.
Great. Can you join the political
Join us in our political push.
advocacy?
Yeah, advocacy.
I should add to that if anyone would like to join Strongyloides Australia, this group, it's $50 for students, $100 for non-students. I'm going to put a link to our website and to the membership page in the comments for anyone who might like to join us.
I think I put it in there already, but go ahead again.
Well, thanks everyone for joining today. It's been a great talk from Wendy and a great discussion from our panelists and some fantastic questions. And we really hope that we've raised awareness of Strongyloides to the group, to the participants here today. And you know, as we said, if you're interested in joining, please come along and contact us. If you have any questions, you know, please send us any more questions. I think there's an email there on the website that you can send inquiries through. And again, thanks all for coming today. It's been a great event. So just to remember that, you know, the main thing is for strongyloiditis is to end the neglect. So thank you.
Okay, there was one more thing that came through from Vito. Sorry, not to add that fenbendazole 5 days seems to work in dogs. Does anybody, I mean, Richard, you might know about that. I've never heard of fenbendazole, but anyway.
It's used in veterinary preps. I think Vito's the expert on that one, so I'll leave with what he said. Thank you.
Okay, terrific. Thank you. And all, thank you so much for coming. We really look forward to making contact in the future. I'm sorry we weren't all in Canberra, but this has been an excellent free webinar, and we encourage any membership. Of course, that's the only way we raise money to do anything. So thank you very much, and thank you panel members and colleagues and friends. We will see you on the next run, hopefully soon. Thank you.
Thank you.
Thanks.